The first speaker we have is Dr. Mazen Khairallah, infectious disease and critical care specialist, which is, I want to say a weird combination, but he's the only one I know of, so that's why he's unique. So he is also an associate professor, University of North Dakota. He has talked many times about coronavirus, and he was in Saudi during the MERS epidemic, so he knows a little bit about epidemics and pandemics. So we will start with him. And then again, once we are done, we will allow adequate time for discussion because again, the purpose is for all us to learn. So with that, Dr. Mazen.
Thank you very much, everyone. Thank you, Abdel Ghani, for the introduction. Yes, it is a weird combination between infectious disease and critical care, but it is very applicable to the pandemic that we are living right now.
A common time.
Right. The other thing is, I think both intensivists and internists will benefit from this, because what we're going to be learning is that early detection of those patients with phenotype L is very important. And we're going to explain that in details. I want to mention that most of the concepts that I'm going to present are based on Dr. Gattonini's lecture and published article that will be in the Intensive Care Medicine Journal very soon, and also by the lecture of Dr. Camborata. So its online lecture is available at the ESICM website. With this, I would like to start. We all know by now that the virus is getting into the cells through the ACE2 receptors, and inside the cells, it will replicate and gets into the cytosols before it is released. It generates multiple reactions at the cellular and humoral immunity system in the body. I'm not going to get into details, but the outcome of this would be what we call cytokine storm. It is mainly indicated by an increased level of interleukin-6 that we measure to see if the patient is eligible to get a specific treatment targeting the interleukin-6 in severe cases. And the other thing is I want to mention is you probably did not get into this level of details, including myself, to know what are the different receptors in the vasculature and in the lungs that are affected by angiotensin 2 and the metabolites of angiotensin 2. But I want to simplify this by stating that we have the green color is the results of the conversion of the angiotensin 1 and 2 by the effect of the ACE2. And the red color is the effect of the angiotensin 2 by directly on those receptors through other metabolites also, which is angiotensin 3 and angiotensin 4. And what I want you to notice here that we have kind of opposite effects on the lungs. What you see here is mainly in the green color, vasodilation, anti-proliferation, anti-inflammation, and anti-fibrosis. What you see in the red color here is vasoconstriction here and vasodilation here, but everything else is the opposite. We see proliferation, inflammation, and fibrosis. So I want to say that there is a balance in the lungs between the receptors for the angiotensins compounds differently. And this balance is what keeps the lungs at its steady state without having increased inflammation. In fact, some of those metabolites and receptors are actually studied in inflammatory lung diseases. And the imbalance that we see between these receptors and the effects of those receptors would actually explain much of what I'm going to be talking about clinically. What I want you to get out of this slide is the following. We will have, in those patients, we have imbalance between the effects of vasodilatation and vasoconstriction, more towards vasodilatation. And we will see what we call abolishment of hypoxemic constriction or vasoconstriction. Usually when we have hypoxemia, we have vasoconstriction. What we see here is we don't see the vasoconstriction. What we see is vasodilatation. We know also that those receptors are not only present in the lungs, but also present in the heart, in the kidneys, in the testicles, vessels, and the brain. That's why we see different manifestations of the disease. And we're going to be talking about that specifically.
Mm-hmm.
I see that there is, I'm sorry, there's some writing on my slides. Can we, somebody by mistake, just undo or delete, erase, because it's going to obscure all the slides throughout the presentation. Did you see that?
All right, carry on, doctor. I'll fix it.
Okay, thank you. The other thing that we learned about this disease is that we have different patterns and different courses. Thank you. And you already seen those patients presenting to you in very severe hypoxemia, severe respiratory distress, leading to immediate intubation, mechanical ventilation, and possibly death. This is the hyperacute presentation. We've seen also cases of indolent courses, where we see moderate hypoxemia and moderate work of breath. They get better over days, but more likely they take weeks before they get better. We've seen cases between 2 to 8 weeks. And the third course would be a biphasic. And this is seen in good percentage of cases where initial indolent course followed by acute deterioration and hyperinflammation. This typically or usually occurs on the 5th to the 7th day after the initiation of the disease. Now we've seen the outcome of this disease in multiple studies, and they summarize them in this slide here, where the ones within the red box are the ICU cases, and this is what I'm going to concentrate on. But in general, the percentage for ICU admission of all patients who came to the hospital is between 20 to 30% of the cases. The cardiac toxicity seen in patients with severe disease between 7 and 17%. Shock was seen in up to 9% of the cases, and invasive mechanical ventilation was done in between 5 to 17% of severe cases in the hospital. If we take a look on patients who are admitted to the intensive care unit, and we have 4 studies, 2 American studies, small ones from Washington mainly, and big one from Italy, and another one from China. The cardiac toxicity was seen around 25 to 1/3 of the cases, except in the one of the American study did not have any cardiac toxicity in those 24 patients. The Italian study did not mention anything about cardiac toxicity. Shock is seen up to 2/3 of the cases. Invasive mechanical ventilation is required in between 40% to 71%. And as you see, mortality is as high as 2/3 of the cases died in the intensive care unit. The Italian study is 26%, but notice that we have at the time of publication, they had 58% of the patients are still in the intensive care unit. So it is expected that the mortality rate would be likely more than 50% in the Italian cohort study. We've seen also that the same level of severe hypoxemia is manifested with two different X-ray manifestations. On the left side, this is a patient with severe PF ratio, less than 200. And on the right side is also another patient with more infiltrates on the chest X-ray and severe hypoxemia at the same level. And also this patient with increased bilateral infiltrates have shown severe hypoxemia. So severe hypoxemia with different X-ray findings on the chest X-ray. We are hypothesizing that the different patterns are dependent on, number one, severity of the infection, host response, physiological reserve, and comorbidities. So we've seen different manifestation in different hosts. The most important thing is the ventilatory responsiveness of the patient to the hypoxemia, and that's what we're going to explain. And then the time elapsed between the onset of the disease and the observation in the hospital. Maybe those patients are presenting late to the hospital after initiation of the disease. It is probably an atypical ARDS. It doesn't look like COVID-19 leads to typical ARDS. And this is based on the publication from Dr. Gattinoni that was published in the ATS last month. And showing in this graph here on the left side, you can see good percentage. This is a compliance. And what we know about ARDS is that the compliance is very low usually. And you can see good percentage of patients with good compliance, above 50. At the same time, they have severe hypoxemia. So there's a dissociation between the relatively well-preserved lung mechanics and the severity of hypoxemia. At the same time, in the same article, they measured the shunt fraction relative to the fraction of gasless tissue. And this is typically in ARDS is about 1.25. What they found in COVID-19, it is 3.0. So it's almost 3 times higher. And this is towards shunting. So the shunt is much more severe in COVID-19 than in typical ARDS. So they concluded that we're likely dealing with remarkable hyperperfusion of gasless tissue. That doesn't mean that those patients may not respond to PEEP or proning position. With proning position, we may redistribute the perfusion in response to different pressure or gravity. So the conclusion is COVID-19 pneumonitis is not ARDS. So what is this disease? What we know that we have physiological abnormalities. As I said, dysregulation of pulmonary perfusion. We've seen microthrombosis, that means there's dead space disease, and we've seen collapse and ARDS-like picture, that means it's shunting process. There's also neurotropism, meaning the virus may affect the brain and mainly the midbrain, causing cognitive problems, and that's why a lot of those observations that we've seen initially, there's dissociation between the work of breath and the perception of shortness of breath. Patients are hypoxemic, they have high work of breath, but they don't feel that. Also, it's been described in some cases with cardiorespiratory arrest due to inhibition of the centers in the midbrain directly, most likely. Higher rate of delirium, and also, as you've seen in the JAMA, anosmia has been described. Radiologically, we have mentioned that ground glass opacities localized or diffuse infiltrates bilaterally with consolidation. And more importantly, mechanically, we were able to differentiate between 2 different types. the low versus high, and we'll explain that in terms of elastance, the VQ, the lung weight, recruitability, and PEEP. So in this slide, I'm going to propose the different mechanisms and put them together so we can understand this disease. So the first thing, the virus gets into the lungs and causes dysregulation of pulmonary perfusion, and also abolishment of vasoconstriction, of hypoxic vasoconstriction. This leads to VQ mismatch on the expense of more perfusion. So it is shunting because of dysregulation. That's number one step. As a result of this, the patient will breathe deeply with larger tidal volume. At the same time, there's a neurotropism that we talked about that will cause an increased respiratory drive. This increased respiratory drive will increase the work of breath, and the patient will breathe deeply. Number three, there is a possibility because of the local inflammation in the lungs that it's not a possibility, it is confirmed in autopsies that there is microthrombosis too. If we have microthrombosis, it's like small emboli that will lead to dead space disease here, meaning more work of breath for those patients. Also, the virus has a severe inflammatory reaction in the lungs and cause direct acute lung injury. As a result, the patient will have increased elastance and they will have increased work of breath. That increased work of breath is the main cause of what we call patient self-inflicted lung injury. The patient will create large transpulmonary pressures, and those pressures will be responsible for imposing more stress and strain on the alveoli, which will lead to self-inflicted lung injury. At the same time, there is increased metabolic demand in the body, high minute ventilation that will add to the work of breath. So we need to understand the work of breath is the most important factor in determining how the patient is going to progress. So we have impaired gas exchange, and later on we'll have decreased lung elastance, increased lung elastance, decreased compliance. It will lead to increased respiratory drive that will lead to self-inflicted lung injury. It will cause more capillary leak. It will cause more lung edema, and then increased lung elastance and impaired gas exchange again. So it is a vicious cycle. So if we start with hypoxemia here, the hypoxemia initially, early on in the disease, is caused by dysregulation of pulmonary perfusion. So the lungs, the lung gas is normal. Alveoli are normal. There's loss of hypoxic vasoconstriction and loss of regulation of perfusion. So this is the main pathology that is likely is causing the problem. This is described as phenotype L, and L stands for low. And that is because those patients have low elastance. This is the opposite of compliance. High compliance, normal compliance, low elastance. Low VQ because the Q is elevated here. Low lung weight, low recruitability, and low PEEP. They don't respond to high PEEP. They don't improve with high PEEP. At the same time, we have pulmonary microthrombosis here. On the other hand, we have patients with pulmonary edema, collapse ARDS-like. And we call them phenotype H, which is the opposite of everything. They have high elastance, low compliance, high right to left shunt, high lung weight, higher recruitability, and they require higher PEEP. And of course, patients can progress from phenotype L to phenotype H based on the severity of the disease, the depth of the intrathoracic pressure. That's why I emphasize on the work of breath. That is what causes increased tidal volume. that will lead to increased interstitial lung edema and patient self-inflicted lung injury. In the Gattinoni study, 20 to 30% of cases were phenotype H and the rest were phenotype L. And this is the same patient in difference of 7 days. The first CT scan here is where you see more gas than infiltrates. This is ground glass infiltrates. You can see here the Hansfield units indicating well aerated compartments. The total lung weight was around 1,100 grams only. 7.8% was consolidated, not aerated, and the gas volume was 4,200. The same patient progressed after 7 days with a shift to the right with non-aerated compartments. You can see how consolidated the lungs are here. Total lung weight has increased to 2,700 grams. More than 50% was not aerated, and gas volume decreased to 1,360. So this is phenotype L, progressed to phenotype H. In the way we manage those patients, we need to go through steps, starting with shunt fraction estimation, determination of risk of self-inflicted lung injury, then phenotype screening, phenotype identification, and then escalation if there is no response. So we estimate the shunt fraction basically based on the response to the oxygen. This is very basic in lung physiology. We put the patient on 15 liters per minute and we look for the SpO2. If the SpO2 increased more than 95%, that means it is mild shunting process. If it did not go above 95%, that means it is severe, moderate to severe shunting process. And you can see here the fraction of the shunt related to the response to the oxygen. So this is the increased FiO2 here, and this is the PO2. So if the response is very good, and we get a PO2 elevation, that means the shunt fraction is minimal, compared to a poor response with slight increase in the PO2 that indicates higher shunt fraction. So the question is, those patients, should they be placed on non-invasive mechanical ventilation, or they should be intubated? Should they be intubated? So if they require FiO2 more than 40%, the next step is, before we say should we put him on non-invasive high flow nasal cannula or should we intubate the patient, let's estimate the work of breath. So this is the most important step, and that's why I said the internists will benefit from this, because you really need to define those patients who have an increased work of breath. Unfortunately, there's no good way to estimate this, because the best way is to put esophageal manometry probe and measure the intrathoracic pressure. That is not available in many places, and it is not practical. Usually we put it on patients who are on the ventilator and paralyzed. So we can estimate the intrathoracic pressure if we have a central line placed in the subclavian or the IJ, and we can look at the swings in the CVP. If we have a deep swings, that's a very large intrathoracic pressure. But this is also not available for you all the time, and you're left with a clinical detection of excessive respiratory efforts. Take a look on the patient, see the respiratory rate and how deep the patient is inhaling, and you have an estimate of the intrathoracic pressure. In general, if that intrathoracic pressure is less than 10 centimeters of water, the work of breath is low. If the patient is exerting using accessory muscles, like, you can estimate it based on what we learned from asthmatic patients with a deep breathing, this is more than 15 centimeters, that work of breath is high and may be injurious to the lungs. So those patients with the low work of breath may benefit from a trial of CPAP, and look, put the CPAP first and then face masks or non-invasive mechanical ventilation. However, if we do this, patients should be in negative pressure room for the risk of transmission, and it should be for limited time only to see whether the patient responds or not. And it should be with continuous monitoring of work of breath. If we feel that the work of breath is increased for that patient, or they are not responding to this, we intubate those patients. And once you intubate those patients, you have a better way to assess work of breath based on, dependent on the ventilator that you're using, with a PEEP in the first 0.1 seconds. What's the pressure generated inside the chest in the first 0.1 second. So the third thing we do is we screen for phenotype. And this is, we assess what we call the strain. And this means what is the driving pressure? The driving pressure is the difference between the plateau pressure and the PEEP. So the more driving pressure we exert on the lungs, the more strain we put. Strain is defined as the change in the volume or the shape to the pressure applied. How much pressure we put, what is the changes occurred because of that pressure. So if we have a pressure more than 15 centimeters, that means that we have a high strain. So we look at driving pressure. If it is less than 15 centimeters, that we can do a tidal volume of 8 ml per kg. So once those patients are intubated, we generally put those patients on 8 ml per kg of ideal body weight, put them on PEEP of 8, and adjust the rate for the end-tidal CO2. And then we look at the driving pressure. If it is less than 15, we keep that tidal volume at 8 ml per kg. However, if it is higher than 15 centimeters of water, that means there is high strain, and we need to reduce and transform to protective lung strategy with 6 ml per kg of ideal body weight. We like to minimize fluid. However, you need to pay attention that they've seen higher rates of renal injury. And what we like to do is optimize fluids based on hemodynamic targets. IVC diameter or stroke volume variation or anything else. The other thing is question mark here, whether low-dose pulmonary vasoconstrictor would help. I have not seen studies about that yet. And then we identify the phenotype. So those patients, if they require higher FiO2, we may put them on neuromuscular blockade. And if we need to increase the PEEP, we increase it in increments of 2 centimeters of water, but we don't go higher than 16 centimeters of water. And we check for the compliance. If the compliance is more than 40 ml per centimeter of water, that means they are phenotype L. If the compliance is less than 40 milliliter per centimeter of water, that means they are phenotype H. So this is a low elastance, high compliance, and this is high elastance, low compliance. So those patients can continue on tidal volume of 8 ml per kg, and the PEEP should be around 8 to 10. So those patients do not have lung edema. They do not respond to higher PEEP. But they may respond to Browning position because of what we said about the gravity and the pressure applied to different parts of the lungs. It may shift these these vessels around. In phenotype H, those patients usually are Brown responsive, and they usually respond to higher PEEP, and as I said, not more than 16 centimeters of water, and recruitment maneuvers can be beneficial for those patients. They improve oxygenation after this recruitment maneuvers. If we do it, we do the recruitment maneuver for 40 centimeters of water for 20 seconds only. And those patients may require airway pressure release ventilation, mode of ventilation, and that is only available on certain ventilators. And the last step is, if the patient does not get better, Patient continues to have refractory hypoxemia, not responsive to proning position or ABRV for more than 6 hours, or even sooner in life-threatening cases. At that time, you evaluate your patient if he's or she candidate for ECMO. If the patient is candidate for ECMO, you make a decision whether they should go to VV ECMO or VA ECMO if they have cardiac collapse at the same time. If they are not candidates or it's not available, the only thing you would do is discuss goals with the family and see what you're going to do next with the patient. That's all what I have. Thank you very much. I hope everyone stay safe.
Can we have questions? We can have some, this is Fuad, or if Dr. Imad can cover also the ventilation and then move to half hour of question and answers and discussion. That's fine.
Should I stop now or?
Reminder about if you are interested in CME, you need to email. We're gonna repeat the slide later about the CME. There's 2 CME activity from Indiana University. I will leave it back to Dr. Shihadi now.
Okay, is my voice clear?
Yeah, we can hear you very well. Can you share your screen, please?
Yes. Okay.
Perfect.
Well, thank you, Dr. Khairallah, for that excellent presentation. And the points I'm going to try to cover now is basically some of the practical issues that we had to deal with, you know, in taking care of these patients. And the 2 points that I would like to cover basically when to intubate these patients, and also the safety and the efficacy of using high-flow nasal cannulas and non-invasive ventilation in these patients. Regarding the first point with intubations, and you know, most of the data that came out of China basically recommended early intubation in these patients, and the benefit that you can get from that is that with mechanical ventilation, using a low tidal volume strategy, you can actually cause less injury to the lung rather than allowing a high transpulmonary pressure in patients who have a high work of breathing and they vigorously have spontaneous breathing, or you're using non-invasive ventilation in those patients. So this way you can actually protect the lung more rather than leaving the patient breathing on their own. The second thing is basically with the decreasing the risk for the staff who's taking care of these patients. As you know, the intubation process itself has a high risk of exposure, but then after that, it's mostly breathing through a closed circuit, especially if we use viral filters, and there are not a lot of aerosolization that happen, with mechanical ventilation, and therefore the risk for the staff, especially the nursing staff, who comes and goes inside the room like multiple times during the day, will be much less than when you use somebody on non-invasive ventilation with high frequency nasal cannulas. The other thing also that you would like to always do the intubation in non-emergent situation. And the reason for that is number one is decreasing risk of exposure to the staff, because you have to allow time for the staff to don the proper personal protective equipment. You have to make sure that everything is available at the bedside, that it is that everything is under control situation, and therefore trying to minimize the risk as much as possible. And also those patients unfortunately can suddenly deteriorate, and a lot of times you can end up with a cardiac arrest of these patients if you delay intubating them to the last minute. So that's why basically the idea of early intubation in those patients came along. However, there is the reality of the situation. I can, speak from personal, experience that our goal at the beginning when we tried to deal with the outbreak in Michigan in the hospital I'm working at is to try to avoid using non-invasive ventilation as much as possible. We have a total of 50 ICU beds prior to the onset of the COVID-19 outbreak. We designated one unit, 12 beds, to be COVID dedicated units. That's at the beginning of the outbreak. And then we decided to intubate all these patients immediately. Now, by the end of the first week, all the units, the 4 units, were transferred into COVID-19 units. We almost ran out of all the usual ventilators, the PP840 and the Hamilton H5 ventilators. And we started to move into using portable ventilators and anesthesia machines to try to ventilate patients. We started to trickle down to the OR and the PACU to use ICU beds, and we did not have enough staff to take care of these patients. So that's why we have to, kind of take a step back and decide, do we really have to be aggressive with this, process or no? The second thing also that when you intubate these patients, a lot of these patients will need a lot of medications to keep them sedated, to control their work of breathing, and all the risks that's associated with this type of approach on the cognitive function, the risk of critical illness myopathy, and all these complications that can happen. And also we noticed that the pharmacy is running short of medications to sedate these patients very quickly. And we started depending actually on using oral medications to provide sedation and analgesia for some of these patients. So we had to do something different. What we were doing was not working, and we'll be really be put in a very tough situation to continue with the same approach. What should we do? So the dilemma that we noticed that a couple of things. One, if you go, if you have taken care of a COVID patient, you've noticed a lot of those patients, as Dr. Kerala, said earlier, they will tell you they feel fine. I mean, they're breathing like 35, 40 times a minute. They're sitting there talking to you in full sentences. They don't seem to be really in a lot of distress, but they make any kind of movement and their saturation drops immediately in the 70s, but doesn't feel that they have any issues. Their organs are functioning fine, everything looks okay, but if you look at their numbers from oxygenation standpoint, it looks pretty bad. Those patients, 2 or 3 months ago, you will intubate them without blinking, but now things are different. The second thing is, does mechanical ventilation really help on these patients? I mean, as Dr. Kerala's slides earlier indicated, that the ICU mortality in a lot of these patients were more than case series were more than 50%. So the case series from Italy showed that 99% of the critically ill patients in the ICUs required some type of respiratory support. Only 11% were in non-invasive ventilation, and the overall mortality was 26%, but there was still a lot of patients still in the ICUs at that time. Wuhan case series showed that out of 37 patients who required mechanical ventilation, 30 patients died. In Seattle, also a high mortality rate. Patients older than 70, most of them did not survive. Patients less than 70, about 36% also did not. So what is currently the recommendation? So the other, option, of course, if you don't, you want to use the mechanical ventilation, is to try to do a trial of high flow nasal cannula or non-invasive ventilation. So what is the evidence that we have so far? So the Society of Critical Care Medicine, and also through their surviving sepsis guidelines that was issued at the end of last month, they gave basically preference of using high flow nasal cannula compared to non-invasive ventilation. And most of the studies basically are not COVID-19 patients. Most of it depend on the use of high flow nasal cannula and acute respiratory failure and ARDS related acute respiratory failure, and also looking at some of the outcomes and using non-invasive ventilation and other outbreaks that was similar to COVID-19, like the previous SARS outbreak and also the MERS outbreak, a few years ago. One of the main concerns also was the risk for healthcare workers, basically the exposure of the aerosolized, that happens from using these devices, especially with the non-invasive ventilation. There was a lot of evidence that coming out that after aerosolized procedure, droplets can actually stay in the atmosphere for up to 3 hours afterwards. And you have, nursing staff, respiratory therapists, nursing aides that's going in and out of the room, multiple times during the day. They still, they did not really ban the use of non-invasive ventilation completely, but they left it up to the discretion of the treating physician to trial in a short period of time, and also to have patients very closely monitored during that period of time. What should we use? High flow nasal cannula or non-invasive ventilation? There is a new study that was published in the Annals of Intensive Care Medicine just recently, included a case series from China that had 27 patients in it. 63% of them were tried in high flow nasal cannula. 7 out of those 17 patients ended up needing a non-invasive rescue therapy, and two of them eventually were intubated. And 33 patients were tried on non-invasive ventilation directly instead of high flow nasal cannula in the beginning. And one of those 9 patients eventually intubated, and only 1 patient that went directly for mechanical ventilation. And overall, at the end, about 4 patients, or about 15% of them, required to be intubated. All the failures of using the non-mechanical ventilation, basically high flow nasal cannula, non-invasive ventilation, were in patients with PO2 to FiO2 ratio of less than 200. So that's one of the things that can help you and make a decision whether you want to try high flow nasal cannula and non-invasive ventilation prior to jumping directly to intubating the patient in these cases. So I will talk a little bit about my experience, basically dealing with these patients. So over the last, and this is not official data, but over the last 10 days, working at the Bowman Hospital in Michigan, I took care of about 65 patients with COVID-19 pneumonia outside the ICU. So this is not patients that were admitted directly to the ICU and transferred out of the ICU later on. This is patients who came from the ER to the medical floor. Those patients, the one that I listed here, the 65, had oxygen requirements more than 6 liters per minute. Out of those 65, 14 patients went on non-invasive ventilation. The usual approach we had is to start with the CPAP, and then if the patient basically is not improving, or they have a lot of work of breathing, we move to PI level support afterwards, but initially we will depend on CPAP first. So out of those 14 patients, we have 5 patients who were transferred to the ICU, 4 were intubated, but 1 remains on non-invasive ventilation in the ICU, and he's been there, or she's been there for about 3 days now, still on BiPAP support. The people who were intubated, 1 was intubated very quickly after starting the non-invasive ventilation trial. It was obvious that he was going to fail, and he remains intubated. We're all not doing well. He's in kind of multi-organ failure. 2 out of the people who were intubated because of non-tolerance of the non-invasive, mostly because of claustrophobic and problems with the mask, rather than failure of the trial itself because of increased work of breathing and aggressive hypoxia. And 1 of the people who also were intubated was on non-invasive ventilation for 3 days in a row prior to intubation, and she was intubated because of increased work of breathing and progressive hypoxia. Out of those, 4 patients who were intubated, 3 were extubated within 96 hours, and 1 of those was self-extubation. 11 out of the 14 patients who required non-invasive ventilation have already been discharged from the hospital. And our experience that with the patients who were being on non-invasive ventilation, most of them stayed on it for more than 2 days. So generally, in regular times, we typically do not continue patients on non-invasive ventilation for that period of time, but because of the lack of resources, we have to change our approach and try something different and see if that will affect the patient outcome. And from our experience, and this is only my experience, but I'm talking to the other pulmonologists and intensivists who works in the hospital, they all have a consensus now that using non-invasive ventilation can decrease, the risk of intubation, the risk of intubation in many patients, and can save you ICU beds and resources. Regarding high flow nasal cannula, we are not using it much, and main thing is We don't have enough of them in the hospital. We have many more pipettes and CPAP machines compared to the typical high flow, optiflow, or vapotherm devices. We do have a lot of the low high flow nasal cannulas, the one that goes up to 15 liters, and a lot of the patients are using these. But the true high flow nasal cannulas, we don't have a lot of them. And there is still a lot of concern about aerosolization with these machines also. Because there is really no evidence saying that they don't aerosolize a lot of viral, viral droplets too. And there is some, concern that any kind of, supplemental oxygen in a patient's spontaneous breathing, you're going to have some aerosolization with it, regardless of what device you're going to use. The other thing that kind of limiting our use, and compared to the pipette, that the pipette and or non-invasive ventilation in our institution can be applied easily by the nursing staff, but for the high flow nasal cannulas, it has to be basically prepared by respiratory therapists and maintained by the respiratory therapists, which makes things much more complicated from their end. The other thing from our experience regarding the work of breathing on these patients, that we stopped looking at the respiratory rate. We found out that physically it's irrelevant. And most of these patients, a lot of them on the pipette, they're still breathing in the 30s, and they stay on it for like several days without having any deterioration in their condition. And a lot of the patients that I've seen have come out of pipette and went home despite these episodes or periods of time when they're breathing very fast. So the main thing that we're depending on in deciding that the patient is failing the non-invasive ventilation trial and moving to the next step with intubation is basically whether they have progressive hypoxia despite the non-invasive ventilation, or they have other signs of increased work of breathing, like use of accessory muscles, change in mental status, or the patient report that they cannot breathe. And in that case, we basically move to the next step, which is moving the patient to the ICU and moving them on mechanical ventilation intubation at that point. So these are the few points that I wanted to talk to, and then I think now we're open the table for discussion and questions.
Thank you, Imad. Dr. Hamad, did you like to take it, questions, or Fuad?
Sure.
So if you have any question, please leave it in the...
Dr. Hamad?
Yes. So the first question was, how safe is CPAP? And I think that you probably answered that. The CPAP is a aerosolizing non-invasive ventilation. And however, I think with proper PPE, and normally I know in our hospital, they require a patient to be in a negative room, but there's not enough negative pressure rooms. So it can be used, but it's more aerosolizing than the other procedures, definitely.
So I want to speak out of Beaumont health experience also. We do have a large load of patients. The hospital did report a couple of days ago that there is 1,500 health worker at the hospital, including 500 nurses who are sick with COVID-19 symptoms. None of all these are confirmed COVID-19 cases, but that's definitely a large number of people. As we're trying to use it in negative pressure rooms, but like, as you said, Dr. Hamad, that we don't have enough of them. We try to, these patients who are out on pipette machines typically have to be in patients with rooms with windows, so they can be seen, continuously from the outside. All of them are hooked up to continuous pulse oxygen monitors and telemetry. And the pipette screens typically are facing to the outside, so anybody, the nursing staff or the physician, can look at it, multiple times to make sure that the patient is doing okay. But there is definitely a risk of aerosolization. How much is it? I think it's really too early to say. But
yeah. So one thing I know, we have in our hospital, there's a filter that we place on the expiratory limb of the CPAP or BiPAP. And that filter has a specific specification. It has to be a viral filter, and that reduces the aerosolization. Now,
I'm sorry to interrupt. One of the issues also is not only the filter, but the leak from around the mask. And that's probably more risk of aerosolization than going through the typical, route through the tubing. That's why, there are some talks about using the helmet, for the, on those patients rather than using the typical face mask, but there is no clear recommendations or guidelines about that either. But yeah, typically you have to make sure that the patient has a good seal. Otherwise, he's going to be blowing the virus all over the place.
Okay, so second question I have here is, we know that 8 millimeter, and maybe Dr. Khairallah can answer that, the tidal volume of 8 millimeter can sometimes be injurious to the lung. So why are we using this in phenotype L?
In the phenotype L, there is no ARDS-like picture. The lung compliance is normal, elastance is normal. So those patients have only hypoxemia, severe hypoxemia because of shunting, dysregulation of vasculature, vasodilatation. So putting them on 8 ml per kg should be safe. The thing that we should always monitor is the work of breath, because those patients can transform into the ARDS-like picture, where they can develop lung edema if the transpulmonary pressure is huge. So we need to keep an eye on them if the work of breath is high in terms of the tidal volume. I agree with Imad, the respiratory rate doesn't matter much. The degree, the swings, the tidal volume they're taking, if they're taking big swings inside, at that time, if the patient is on non-invasive mechanical ventilation, I would intubate that patient and decrease his work of breath. If the patient is on the ventilator and he's doing this, he needs to be paralyzed.
So there are a couple of questions about treatment. So we're going to defer these questions until after the treatment session. Anybody wants to make comments? Any intensivist or any other?
This is Fuad. Just into the questions about the medical management will be covered in the second hour. I'm seeing a lot of questions.
Okay,
medical
I have
management, steroids. This will be covered.
Yes.
Sorry.
Yeah, Fuad, you're breaking. Okay. Any other questions?
Yes, if I may. This is Assam. I have a questions about the biomarkers, the role of the D-dimer, precalcitonin, or the CRP, and the role in differentiating the phenotype and the cytokine storm, and if there is any role for like frequently checking as indication of progression of the disease or improvements.
Can you let me share my screen?
Isam, can you please introduce yourself? Where do you work and what's your specialty?
So I'm Assam. I'm intensivist critical care, but anesthesia background. I work in Virginia, one of the community hospitals. And we had so far, like what I dealt with is like less than 10 cases, but 3 of them are right now actively on the ventilators. And I think they're exhibiting more of a phenotype 2, the heavy ones, like more the ARDS picture. From what I experienced, and I don't know what other people is like, basically the patient can progress, and you will think so. One patient, actually, we had her for 5 days, observing her on a non-rebreather oxygen, and then we thought she saw some improvements that we downgraded her to a step-down unit, only to come back 3 days later with a full-blown ARDS. So the other question comes up is like, when do we think that the patient is out of the wood? Because we've seen some patients, they fluctuate from getting better, but then getting worse a few days after. And, especially when they start coming with the cytokine storm. So.
Thank you.
Can you let me share my screen, please?
Go ahead, Dr. Khairallah.
So in regards to the first question, those are the markers that predict that there is a high risk of progression to worse disease.
Dr.
When,
Hamad, can you go presentation mode?
Sure.
Thank you.
So in general, the high risk of progression would entail one of the epidemiological factors plus one of vital signs or one laboratory. Once you have any of this, the D dimers, the CK, the CRP, LDH, troponin, even the absolute lymphocyte count less than 0.8 and ferritin more than 300, those are indicators of severe disease, meaning progression from phenotype 1 or phenotype L to phenotype H. So again, phenotype H is more inflammatory disease. It's ARDS-like syndrome, but it did not fulfill all the criteria for ARDS in terms of timing and in terms of compliance. The other thing that you mentioned in terms of the course is this is seen in almost 30% of cases where you would see patients getting better, and then by the end of the first week, would get another phase where they have the severe inflammation with hypoxemia and worsening of the condition. So this is seen typically in around 20 to 30% of cases. That's what everybody is seeing. So we think this is progression from phenotype L to phenotype H.
Okay, one more question about the use of muscle paralysis, paralytic agents. Maybe Imad wants to answer that.
So you can use neuromuscular blockade. The recommendations from the Surviving Sepsis campaign is to use boluses at the beginning to see if you can achieve synchronization between the patient and the ventilator. And if that doesn't work, an infusion is recommended. You can start that at that time. But typically, they recommend to limit that to less than 48 hours to decrease risk of critical illness, myopathy, and long-term complications.
So let me follow up on that. Is there any evidence so far, like ARDS, that paralytic agents will improve outcome or survival? Anybody knows?
There is no studies actually looking at this. I need to search on clinicaltrials.gov if there's anybody looking into this. But theoretically speaking, I think if we're dealing with phenotype L and those patients are on the ventilator and the intrathoracic pressure is increased, I think paralyzing those patients theoretically would prevent transition into phenotype H, and that would decrease the mortality. But we need to see this in a I don't think it's going to be randomized controlled trials, but it needs to be seen in a cohort of patients compared to other patients who did not get paralyzed, maybe external controls or something like that. So this is speculation only.
I'm sorry. We have maybe, we'll allow maybe 5 more minutes for questions before we get to the second half. Or let me see.
I have one question, Dr. Hamada, if you have time.
Sure.
Sure. This is Dr. Al-Zain. I have a question. I mean, is there any evidence for like an etiology that this virus is attacking the hemoglobin? And I mean, the hemoglobin molecule in the red blood cells and ejecting the 4 hemes particle with the iron. And then this iron is going, I mean, to the circulation and it's irritating the liver. And that's why you have like, I know that, I mean, the liver will be affected by the sepsis. So as if you have like increase in the like hemosiderin. The other things that then the virus sits in the hemoglobin protein and multiply. So if that's the case, if there's anyone, I mean, thinking or like if it's getting this, is there any idea of like exchange blood transfusion that might help this? Because exchange blood transfusion will take some, blood from the patient and will replace it with the new blood, so the hemoglobin and the carrier of the oxygen will be intact. If that's right, I'm not sure. I received this, it might make sense, but I'm not sure how real is this theory. The other thing for the microcoagulation and thrombosis, is it like DIC type, and maybe the heparin will sometime work? So I'm just raising these ideas. I'm not sure how practical are these ideas, and if there's anyone has discussed or studied this idea.
So I can answer this. The second question will be answered during the medical part of this webinar. So we have Dr. Abdulrazak is talking about this. But in terms of the first theory that you presented, this is actually submitted to a site called ChemRxiv. And everybody should be aware of this website. And this is only preprint data or articles. This is before submission to official journals to get feedbacks from the readers. And the article that they submitted put a theory of the virus attaching to the hemoglobin parts of it, and then it's like methemoglobinemia. This is based on informatic technology only. It's not clinical at all. It is actually, it used technology called domain analysis, homology modeling, and molecular docking. This is somebody sitting at the computer and looking at different molecules and looking at the similarities between the virus molecules and the hemoglobins. And he hypothesized that this is going to be attaching to it and causing this. And in fact, in the article itself, it says this needs to be proven. This is only theory, it's not applicable.
Sure.
Now, if it was true, it's like methemoglobinemia. What you see in methemoglobinemia is saturation is decreased and PO2 in the blood is normal. Here, what we see is severe hypoxemia in those patients. So I don't think
and methylene, what do you call it? Methylene blue is the one, if that's correct, we'll be able to treat that.
Yes, methylene blue will be, but again, this is non-medical people, biologists and technologists, informatic technology, sitting at the computers and making those suggestions.
So let me ask, there are two good questions. One, and I don't know if we want to leave it now or later, but what is the role of nitric oxide?
Well, if you put it in the concept of vasodilation, it should not work, because nitric oxide is a pulmonary vasodilator. In fact, it will worsen the shunt process. It may have a role in ARDS-like picture, which is phenotype H. However, we know that the nitric oxide is associated with higher degree of renal impairment in the ARDS studies, with the ARDS network studies that we have. So I think I would have a major reservation in using nitric oxide in both phenotype L or phenotype H. But I know that it's been used in some of the Chinese studies also. It's been
I can tell you, in our hospital at Christ, there is probably about 10 patients on ECMO. And you know the surgeons. Everybody who goes on ECMO, once he goes into the surgical unit, and they put him on nitric oxide immediately in addition to the ECMO. We've had good results with ECMO, but I don't know if nitric oxide is doing anything useful or harmful. We have no idea. That's just a comment. So another question, are there any statistics about medical staff who are infected with corona? What is the percentage of them that are taking care of corona patients?
In the Italian study, 10% of patients were healthcare workers. And in our hospital, so far we have close to 15 people infected. In fact, I myself got checked yesterday because I was exposed to another physician who was infected, and it came back negative today.
Oh, congratulations.
Well, it has a false negativity also.
Yeah. Oh, a question. What is the false negativity of the swab test?
You want to answer that, Imad?
Yeah, so going back to the first one about the, the stats about the healthcare workers, as 1,500 out of Walmart Health System have been out with COVID-19 symptoms, including 500 nurses. In Henry Ford Hospital here also, which is the, one of the major health systems in Michigan, there have more than 700 people out with COVID-19 symptoms. Now, the one we're using right now is the rapid assay that came up with Abbott. So we started using this, this week. Basically, the reported false negative results that we were told is about 30%. A lot of that also depends on the technique of obtaining the swab. You have to really go deep into basically all the way up to the nasopharynx really to get a good sample. If the patient doesn't know you, if the nurse does not do a good job in doing it, then you may have an increased rate of false negativity. Also, the longer the symptom duration, the higher the false negative results from the nasopharyngeal swab. It can go down to less than 50% after 1 week from having symptoms. So in those patients, you probably have a better results with obtaining an into lower respiratory tract symptoms or basically tracheal aspirate. I mean, I have a personal experience with one patient who was intubated who was the first 3 nasopharyngeal swabs were negative, and then after he got intubated, we got a tracheal swab that came back positive. So if you're suspecting, you should treat it as COVID-19 and do not stop isolation. Definitely do not stop treatment.
All right. So 2 more questions, and then we have to move on to the next phase. So first, there's a lot of dentists, and Dr. Athman Shibli here, speaking for them, I guess. And he said, what is the best advice for the dentists?
Close your practice.
That is true, actually. If because most of those procedures are sterilizing
patients. We are seeing emergency patients in the university dental school, and so any precautions, extra precautions. We are not drilling anymore because of aerosol, so we are not drilling anymore.
Any procedure that is associated with aerosol generation, you should wear the N95 with the eye protection in addition to the gloves and the body, the gown.
Okay.
Actually, if I may add, I mean, I think you probably as a dentist, if you're gonna have a procedure, you might have to use like what they call it, the PAPR, like so basically a helmet go over your head and shoulders, and that's usually attached to negative pressure. So that would be much more protective. Maybe you can look into that. Some of the hospitals, they're using this for intubation regularly. So if you're
using it all the time, actually, in all our rooms with the papers. So it's 99.7% protection compared to 95% for the N95.
Okay.
So yeah, I think
There are more
you are
questions,
right, 100%.
There are more questions, but maybe we'll leave it till the end. Just one more question before we get to the second point. The second part is there any difference in etiology between younger patients versus older patients?
Yes. In fact, there's an article just published, but it's also theory. They are speculating that elderly patients have less S2 receptors, which is normal with aging compared to younger population. Based on that, they're speculating that the younger population will be at higher risk for infection in terms of the rate. The older population are less likely to be infected. However, the severity of the disease will be much higher in older population and patients with cardiovascular disease compared to the younger population. And they think because of the downregulation of receptors of ACE1 receptors. So it is again related to relationship between ACE1 and ACE2. Oh, and it's very nice theory actually they presented in JAMA, I think 2 days ago.
Okay, now we need to move on to the second session. And if there are more questions after the second session, we can address them. So we can start also with Dr. Mazen Khairallah. He's going to talk about treatment with hydroxychloroquine for 10 minutes.
Okay, so of course, there's nothing at high level. Everything we're going to be talking about does not reach the level where in normal situation we would be sitting and looking at different studies and deciding whether we should use this or not. We don't have a well-designed randomized control trials. I'm not impressed with any study that is available there. And most of those studies are cohort studies, case series. The only high level that we have is this level. This is what we know, it's above everything. And since he said that hydroxychloroquine should work, so we're trying to make the studies that make this medication work. If you take a look on clinicaltrials.gov, you will see now there are more than 300 clinical trials all over the world, and 3 only completed. One of them is on the efficacy and safety of hydroxychloroquine, which I don't have the results yet. It's completed, but it is not published. And different modality of or different medications have been tried. A lot of those are in clinical trials, and we will talk about some of those options. My job is just to talk about the hydroxychloroquine, and this is where the doctor who asked the question about the hemoglobin, it is heme polymerase inhibitor. And in fact, hydroxychloroquine can cause methemoglobinemia, so you have to be aware of that. But we think the mechanism is related to the entrance of the zinc inside the cells, which would impede the replication of the virus. So it is working with the virus with the mechanism of zinc ionophore effect of the medication. And the initial studies from China are very poorly designed studies, 100 patients, positive results, not impressive at all. The one that I have access to is on MedRxiv, and again, this is the same as the ChemRxiv that I mentioned. It is only preprint. The purpose of this to just put the study and get feedback from people. And in this study, they looked at 62 patients, 31 in the hydroxychloroquine, 31 in external control. There's a decrease in the, there's an improvement in pneumonia in 81% in the hydroxychloroquine versus 55% in external controls. No baseline characteristics mentioned, low number of patients, excluded critical cases, and as I said, external controls, very poor statistical analysis, no confidence intervals. So very big question mark about this study. The study that we rely on is the study that was published in the International Journal of Antimicrobial Agents and looked at hydroxychloroquine and azithromycin in terms of viral clearance. And they looked at PCR and nasopharyngeal swab on daily basis. On day number 6, 70% of patients who were on hydroxychloroquine cleared the virus. compared to 12.5% in the control. And those are external controls also. They concluded that it is significantly associated with viral load reduction, which is very appropriate, I believe. And then when they looked at the combination with azithromycin, 100% of those patients cleared the virus from the nasopharynx. And they concluded also that combination is even more effective than hydroxychloroquine alone. But again, this is only viral clearance. There is no clinical outcome that's measured here. So we don't know if this translated into improvement, but theoretically, scientifically, if you clear the virus, you should get clinical improvement, but we don't know that yet. And this is just to show how the titer came down to 0 in the combination versus 54% in the hydroxychloroquine. And the other study that is available for us is dosing study. And this is looked at 2 different medications, chloroquine and hydroxychloroquine, and showed that hydroxychloroquine is almost 10 times more potent, 5 times more potent than the chloroquine. And they determined the dose to be a loading dose of 400 milligrams BID for 1 day, and then maintenance dose 200 milligrams BID for 4 days. Total course 5 days. You need to pay attention to the side effects of the medication. And where we're going to use it, I don't know. I have no idea, actually. We have decided in our hospitals that we're going to use it for severe cases only. But this is based on that we have limited supply of the medication. In fact, if theoretically speaking, if it's going to benefit, why are we waiting for the severe cases? Severe cases meaning that more inflammation, and maybe it's going to be too late, like the influenza. The more we wait on giving the medication, the worse outcome do we have. So I think it should be used in non-severe cases. No compelling data. It is supply limited. It's going to be restricted, actually. And we don't know about prevention. There is a study at University of Minnesota. They are doing prevention with hydroxychloroquine for healthcare workers who are exposed to the virus. The study that is completed in clinical trials included its randomized control trial, but it's only 30 participants. And it is for severe pneumonia and looked at virologic clearance and mortality. So we're waiting for the results. Hopefully within the next few weeks, we're going to get this. If you go to clinicaltrials.gov and you look for the, you put hydroxychloroquine, you're going to get 18 different studies that looking at using these medications in this medication in different settings of COVID-19. Thank you very much.
Thank you very much. So next we will have Dr. Al-Shitaki. He will talk about anticoagulation, the role of anticoagulation.
Can you make sure you're not muted, please?
All right, are you able to see my slides?
Yes, perfect.
Yes.
All right.
Abdul
My name is Abdurrazzaq Al-Shaqaqi. Good evening, everyone, and good morning for people across the Atlantic. I have very short slides to talk about the observation that we all noticed about COVID-19 coagulopathy. I work in Detroit, Michigan at Beaumont Healthcare. I have no conflict of interest, and the entity or the term COVID-19 associated coagulopathy, I think most of us who dealt with COVID-19 agree on that term. We all see it, especially in the ICU settings. And it is believed that severely ill COVID-19 patients develop coagulopathy, and it is characterized by profound clotting more than bleeding. So many people describe it as a DIC-like picture. The two etiologies that most of people or the expert considering when explaining this phenomena is inflammation drives an increase in fibrinogen that sparks a process of coagulation. And also, as Dr. Khairallah mentioned, the virus can attack different organs. One of them is the endothelial cells that has the ACE2 receptors as well. So there's a concept of viral induced endothelial damage that can trigger a process of DIC picture. What makes this DIC picture a little bit different than the sepsis-induced DIC is the extreme elevation in D-dimer. There's an increase in fibrinogen, especially in the early stage of the disease. Toward the end of the disease, it will be fibrinogen depletion. And the PT-INR, on those patients, is slightly elevated, not excessively elevated that we see in sepsis-induced DIC. And they noticed this form of DIC has mild reduction in the platelets. Lou and his team in a preprint study as well, they did autopsies on COVID-19 patient, and they described a lot of lung necrosis, or in fact, they describe it as hemorrhagic necrosis, and they described a lot of microthrombi as well. So I will touch on two studies here. The first one on the right, this is the study by Nick Tang, and it was in February. And they found a good correlation between elevated D-dimer and mortality. So 71% of non-survivors of COVID-19 patient in the ICU, they had extreme elevation in D-dimer above 3,000s. Or if you're using the other unit, it would be 3 micrograms. Compared to 0.6% of the survivors who had low D-dimer levels. And if you look at the study on the left side here, this is the study by Zhu, and it was released in March. If you look at that figure here, that described the temporal increase in the D-dimer on those patients during their disease course. And when they did the multivariable regression analysis, they found a remarkable association between elevated D-dimer above 1 microgram. That's a reading that happened on admission, not necessarily later during the disease. So if you look at the numbers here on that figure, anyone who comes with elevated D-dimer above 1 microgram was among the non-survivors. Most of them were among the non-survivors by the end of their course. This is a nice figure as well by the same author, Zhu, that described the disease course among the survivors and the non-survivors. And as you can see, it started by some symptoms in the first few days. And around day 7, on both arms, they start having the dyspnea and hypoxia as well. And around day 10 to 11, they go through the bifurcation, whether they just continue their course on the floor and then graduate from the hospital versus getting worsening hypoxia and going in the ICU that requires mechanical ventilation on that red line. And this is where most of us in the ICU deal with clotting complication and accident for those patients when they're critically ill in the ICU. And actually, this is my observation and a lot of my colleagues, we feel those patients are resistant to heparin. You put them on CRRT and you put them on full anticoagulation dose, and you're burning through the CRRT filters like crazy. You cannot fix that problem. And we change their Quentins 2 to 3 times a week. And the question comes, since we're doing anticoagulation during that part of the course and it's not working, is there a role for like early intervention in the previous few days before they get critically ill? That's a big question. And I looked at this study by Langland, and it was released in March as well. They put a proposal for the hypothesis of COVID-19 pathogenesis. And what they found is, after the viral phase, there's a marked increase in the D-dimer levels in addition to other biomarkers. And they found that the proportion of patients who received IVIG and full dose low molecular weight heparin on day 7, between day 7 and day 10, they had a marked reduction in the D-dimer, as you can see here, as well as other inflammatory biomarkers. This is, again, just a proposed pathogenesis figure. Another study unfortunately, the studies are very scarce when it comes to anticoagulation. And this study, I made a lot of hope when I looked at it initially. Later on, when you come to the conclusion, you recognize this is does not apply to what we practice in the United States. So what they found here is, I just need to minimize this. What they found is there's a subgroup of patients who will benefit from anticoagulation. People with sepsis-induced coagulation or coagulopathy score above 4. Those patients will benefit from anticoagulation. However, in this study, the anticoagulation they were alluding to is the preventive dose, the prophylaxis dose, not the full anticoagulation. And it looks like in China, there's no practice of doing DVT prophylaxis on every inpatient get admitted to the hospital. So they started recognizing some microthrombi and some thrombotic accidents on those patients. Then they applied DVT or VTE prophylaxis dose, and they found there's improved mortality at 28 days. It's around probably 24% improvement. Also, they noticed that the patient with elevated D-dimer, more than 6-folds, they will have marked benefits when they receive DVT prophylaxis dose compared to the one who are not treated with heparin. You're talking about 20% reduction in 28 days mortality. This is pretty significant, and it was statistically significant as well. These figures explain the same table. But again, keep in mind, this is a DVT prophylaxis dose only that made that difference, not the full dose anticoagulation. Now, the study that just came like 2 days ago, it's a case series. They described 3 cases in the ICU, critically ill patient with multiple embolic events or thrombotic events in their extremities. And among the tests they sent for was the antiphospholipids antibodies, and it came positive. And looking back in other or previous literature, antiphospholipid antibody can increase in inflammatory conditions. And now the question is, does the antiphospholipid antibody play a role in this thrombotic events? It is not clear. It's just a good observation. Probably we need to pay more attention to this, and probably we need our colleagues from hematology to do their own investigation on this. I think, I'm done with my slides. I think 3 questions that probably we can open to discussion. When would you consider full anticoagulation for your admitted COVID-19 patients? And for how long would you treat? And do you believe there's any role for TEG or ROTAM to look at the risk of thrombosis on those patients? Thank you very much for listening, and I'll open it for the next speaker.
Okay, thank you very much. I think we will proceed with the last presenter, and then we'll open it for questions. But we have Helenos, who is going to talk about the role of steroids.
Hello, everyone. My name is Helenos. I'm a pulmonary critical care fellow on Henry Ford Health System in Michigan, and I'm going to be talking quickly about steroids today. So basically, corticosteroids, when do we use them in COVID-19 patients? Mainly when you're having a hyperinflammatory state with persistent fever, despite Tylenol and antipyretics, when you have toxic symptoms, worsening hypoxia, a patient who's progressively getting worse, 2 liters, 4 liters, 6 liters and above, somebody with a cytokine storm, multi-organ failure, worsening inflammatory markers when you're seeing steep elevations in the ferritin, LDH, CRP with worsening hypoxia, worsening infiltrates on their chest, x-rays or imaging.
Hala, wait, I don't see your slides. I don't know, am I the only one?
You can't see my slides?
I cannot see your slides.
Can you share your screen, please?
Yes. Okay, are you able to see them now?
No.
Not yet.
I hit share screen. Okay.
Coming up now.
Perfect. Okay. So steroids have been tried in prior outbreaks of coronaviruses like SARS, MERS, and it has even been tried in influenza, and we'll talk about that later. It differs between institutions. Like Some use steroids, some are absolutely against steroids. For Michigan, like last, I know the University of Michigan was absolutely no on the use of steroids for coronavirus. Our institution was using them. Other institutions in Southeast Michigan were using them. The choice of steroid depends also on the institution. I've seen some protocols use dexamethasone. Other like institutions use methylprednisolone, and I'll talk about the choice of these medications in the coming slides. So the pro stance, it's really important to know that there were no randomized clinical trials published to date on the use of steroids in coronavirus 19 patients. The current use is based on retrospective studies, a couple of studies coming out from China, from Wuhan. The first one I stumbled upon was by Wang et al. It compared no steroids with low dose systemic steroids, 1 to 2 milligram per kilogram per day of methylprednisolone for a short period of time, 5 to 7 days, in 46 patients. 26 got steroids along with the other standard of care versus 20 patients who didn't get steroids. They observed a shorter duration of supplemental oxygen use. It was around 8 days versus 13 and a half days, 14 days, in patients who did not receive steroids, and according to them, it was statistically significant. They observed improved radiological findings as well. The other studies that was published in JAMA, it was a retrospective cohort study of 201 patients with COVID-19. It showed an association between corticosteroid use and a lower mortality in patients with COVID-19 and ARDS. But again, those are observational studies, no clinical trials so far. Continuing on the pro stance for using steroids, there was a study in influenza A pandemic back in 2009. It evaluated low to moderate dose corticosteroids among patients with PaO2 to FiO2 ratio less than 300 millimeter of mercury, and it showed improved outcomes. And again, as I said, like in the first slide, some institutions use dexamethasone, others use methylprednisolone. I do believe the methylprednisolone, the Solumedrol, are coming from the China studies. Some people use the dexamethasone. There was a recent study coming up from Spain, published in the Lancet, Respiratory Medicine. In early ARDS, they initiated steroids, dexamethasone, 20 milligrams daily for days 1 to 5, and then 10 milligrams daily from days 6 to 10. And actually showed improved outcome. Now, the argument against the use of steroids goes back to the data that we have from SARS and MERS outbreaks. Then it was like the studies that evaluated that, they found that it was associated with delayed viral clearance from blood. There was a study that looked at the use of hydrocortisone that was a randomized controlled trial. It was associated with higher plasma SARS viral load, delayed viral clearance in comparison to a control group that received normal safety. Another study from Saudi Arabia showed that steroid use in MERS was associated with delayed viral clearance from the respiratory tract with no effect on 90 days mortality. So there were also studies retrospectively looking at the patients who received corticosteroids in the SARS outbreak 2003. Like it describes several complications, long-term like avascular necrosis, short-term like psychosis and hyperglycemia and superinfection. Looking at those studies, basically the majority of them, especially on the older ones, they were using high-dose corticosteroids. Like one of them was using 300 milligrams of methylprednisolone per day. Some of them were using like even higher than that. So I do believe the adverse effects were mainly related to the high dose of corticosteroid. That is my understanding of the situation. So what does the guidelines tell us right now? The Society of Critical Care Medicine guidelines, the surviving sepsis in COVID-19 patients, they do not recommend the routine use of steroids for respiratory failure in COVID-19. They have like a murky suggestion to use it in the sicker population with ARDS. I do believe what they kind of like mean, again, like we're seeing hypoxia. specifically because like there's no way to build like a good evidence in the sense that again, the recommendation comes from observational studies, not really well done studies in China, and then the evidence against use of steroids draws back on like our prior experiences, the Cochrane reviews and everything. They kind of like showed more harm than benefit in SARS and MERS and influenza, ARDS. Again, like there are studies that like, or meta-analyses that look at use of steroids in general in ARDS, but like none have specifically looked at viral pneumonia or viral or ARDS caused by viral illnesses. Okay, to sum it up, no clinical trial evaluated the use of steroids yet. There's one trial that's registered from China. I think about use of low-dose steroids is still recruiting. There are no results up yet. I think it started like mid-March or early March. Again, previous data from ARDS caused by coronaviruses show tendency toward harm rather than benefit with the use of steroids can be used for patients requiring progressive increase in supplemental oxygen. This is what a lot of institutions are doing. Our institution is among them. Aim for a low dose, short duration of steroids. A low dose is usually 25 to 150 milligrams of prednisolone daily or equivalent to that. And when we do 1 to 2 milligrams per kilogram, we use the actual body weight, not the ideal body weight or adjusted body weight. It's the actual body weight. And be mindful of complications, like you're risking possible superimposed infections, bacterial infections, hyperglycemia. Like one of our patients in the ICU actually went into DKA initially, and his glucose was really hard to control. So that added metabolic acidosis on top of his respiratory acidosis. Was kind of like a little bit difficult to use. Psychosis, I do believe it's kind of important, especially with putting those patients in a really high dose of sedation to kind of like get them synchronous with the vent and improve their oxygenation. So that can like play into like later when you're trying to liberate them from the vent, and like and those are my references. And thank you very much.
I open it for question. I will ask you, if all the audiences, if you can just maybe give us a comments. Would you like more webinars like this? I know things are evolving. So if there's a consensus and if there's enough people who want, we can develop another one later on to answer more questions and give more updates. So that's just one comment. All right, let's get to some of the questions. I think Abdulrazak had a comment to Hala.
Yes, I think this is comments to Hala and all of our colleagues intensivists. Every time we quote the guidelines from the Surviving Sepsis campaign, which I think these guidelines were put together over 2 weeks. And long as we're sticking to these guidelines, we will be probably killing more people. I think we're exercising the state of sanity. We're not doing, these people are coming and they're dying because we're sticking to guidelines that do not seem to help. In different institutes, actually even the application of using systemic steroids, many hospitals are using it against the Surviving Sepsis campaign. Is that the case at Henry Ford as well? And what is the your department? I like how Ford practice critical care. So what do they do?
So actually for steroids, we're usually pro steroids, and actually there's a study that's going on to evaluate that.
That's why I like Ford.
And I agree with it. Like I've seen it. Like I think the key to giving steroids is giving it in this kind of like inflammatory state where like you're pretty much kind of like cleared the virus a little bit, but like you're still in that inflammatory state and you're progressively requiring oxygen, but you're not at that degree where we have to intubate you and do the full ARDS protocol or full like ventilation. So basically what we've been doing, we get a call from the floor and somebody who's like progressively worsening, and he came up to the floor in room air, then 2 liters, 4 liters. We tell them to start steroids like right away. My observation, we've avoided intubation in some patients that we've given steroids to. Initially, our protocol was given 3 days only. again, it's clinical judgment, like whatever you want to do, that there's no clear evidence to that. We've extended steroids in some cases when somebody was in a cytokine storm. I do believe I saw a question, like based on clinical judgment, we've given tocilizumab as well, like specifically in those patients, like despite steroids, they're still spotting fevers, multi-organ failure, hemodynamic collapse, we've given tocilizumab. Our protocol nowadays says 5 to 7 days of steroids. We do a really low dose, like 0.5 milligrams to 1 milligram. We end up doing 1 milligram, but we're very pro steroids. Again, like it's guidelines, like looking at the studies, everything tells you like no, but again, like the previous studies did really, really high doses of steroids versus like now we're doing like low doses and they vary like that period of time where they're hypoxic, but they're not really in a bad spot. In terms of your question about anticoagulation, we've noticed a lot of our dialysis catheters gets clogged. We've replaced many ones. We actually have,
there's a question about higher dose heparin for those patients. Higher dose, anybody knows?
So the way we practice is basically for, we do anticoagulate anybody who has a D-dimer more than 2,500, and basically they are hypoxic more than 6 liters of oxygen and they have symptoms for more than 7 days. The recommendations that we follow in our hospital is basically full dose anticoagulation using Lovenox if they have good renal function, up to 5 days. You continue after that if there is evidence of venous thromboembolic disease. But as you know, most of these patients we try to limit their movement in the hospital as much as possible. So that's why a lot of times we don't obtain confirmatory tests for that. We just anticoagulate them directly.
So I'm gonna pose a question. I'm gonna pose a question, and I don't know who wants to answer it, but about tocilizumab and the other medications. What are the indications and what is the effectiveness? Maybe Mazen or Abdulrazak.
Let me share the slide, please. So I'm against doing anything that is not evidence-based, by the way. If we start doing right and left medications, so it's okay. We can give steroids, we can give hydroxychloroquine, we can add heparin, we don't know. We don't know if those medications are going to help us or not. What we know that the steroids did not help us in MERS. And those patients did very bad actually because of persistent viremia. The viral load was very high in those patients. It did not clear their viremia, and the outcome was not good. So we don't know in this disease here whether this is going to help or not too. In terms of tocilizumab, what we do is we measure the interleukin-6. However, it's taking time actually, so it doesn't come right away. And if we have 2 of the following, we would start tocilizumab for those patients. Ferritin, you know that it's approved in China by their local FDA, whatever they call it. Ferritin more than 2,000, LDH more than 1,000, CRP more than 5 milligrams, D-dimers more than 3, and progressive lymphocytopenia, troponin more than 10. I think this is the same criteria which Abdul Ghani sent me actually. And that's what you're using at CRISE 2 in terms of the severity or inflammation criteria. But it's mainly for cytokine storm syndrome. And once we get the interleukin-6, we can adjust because we really need to have a high level of interleukin-6. So we get the IL-6 first, and then we start tocilizumab. Of course, it's very expensive. I think it's $10,000, and then we adjust based on the level.
Anyone has, and I have one, but it's based on experience, not on data. A treatment log or protocol that includes all the steroids, when you steroids, I mean, I have one I can share with all of you, but anyone else has something?
I just want to say that there are 8 studies actually now looking at tocilizumab if you go to clinicaltrials.gov.
Okay. Any other questions?
Quick question, Dr. Mazen. Dr. Mazen, do you think the pathophysiology and the pathogenesis of MERS is similar to COVID, or you think COVID is behaving differently, since we're talking about steroid outcome in MERS?
Well, it's actually, if you want, it's completely different disease. We have seen in terms of transmission, it's completely different dynamics. With MERS, those patients presented with severe disease right away. They did not have disease. So, and that's why it was contained very easily in Saudi Arabia and other countries, because those patients declare themselves easily by severity of the illness. So they come to the hospital, most likely they are intubated, and they stay in the ICU for a long time. Mortality rate was 34, 35%. So the similarities in the genomes is 50% only. It's more similar to SARS-1 than MERS. So I don't think that it has some similarities, but I don't think they are similar diseases in complete. The course of the disease is mainly respiratory over there. Now we see here cardiac, we see neurologic involvement, we see kidneys, and coagulopathy. So it's the spectrum is very broad here. Over there, we were mainly looking at pneumonia, severe, going into ARDS, and you get the complications that we see in like any other ARDS with those patients. So I do believe that they are different. There is some similarities, but they are completely different diseases. Now, I cannot apply the steroids that we use in MERS here, but the concept of steroids also in H1N1 was the same. The viral load did not go down, it increased. Outcome is not, in some of the conflicting studies actually, some of the studies outcome was worse. I have not seen any viral infection that steroids would do well. Maybe when the inflammation is severe, yes. However, here the patients are not clearing the viruses. The viral load continues to be positive. The swab, the PCR continues to be positive for weeks. So you're starting steroids and a patient with inflammation at the same time, he still has the virus. So I don't know about the outcome.
And I think the problem is the cytokine storms that we see in COVID. I don't know if it was described as often in other viral infection or even bacterial infection. And when I talk to my colleagues, this is an observation from my round in the ICU. Like today, I had like 30 or 28 patients. Most of them, all of them actually ventilated. And they're not giving me a hard time oxygenating. I'm not struggling with oxygenation. I'm struggling with their kidneys. So I don't know if the steroid is needed more for the cytokine storm to help the kidneys and other organs, not just the lungs in particular. In nephrologists, they're like, it's still mind-boggling to a lot of other
I agree with you that there's inflammation and steroids may play a role. What I'm not sure about is the outcome, whether the steroids will worsen the situation by more viral replication.
I agree.
So what I'm saying is like we're doing something because we're seeing one part of the picture, and then we don't know what happens next. Without a well-designed, randomized control studies, I think it's very difficult to. In fact, actually, steroids has been always difficult to determine in all kinds of diseases. Actually, even for ARDS, it's like we never had a good answer with any study where we say that yes, for sure, steroids will help. Yeah, no, it doesn't help. It's always there's questions in Mendes. Like some people would use it, others do not.
It's like
so we have this.
It is like the shock in the ICU,
also,
right?
it's like yes, there's more agreement now about shock. So at least it's a small dose for 4 or 5 days. They stop it, and we see that there is reversal of shock. So we are more convinced about it. But yes, we debated so much about using steroids in shock even. and in meningitis, in pneumococcal meningitis, and pneumococcal pneumonias too. So I don't think we're going to have an answer. It's going to be left like that. People would be pro steroids, would use it, and others do not like to use it. I'm from the other side where I don't like to use it unless, I give up.
So there are two interesting questions. We've all heard about the BCG vaccination, and it's possibly protective. So that's why we, from Syria, all these guys who had the BCG are not infected. So what's the status? And then the other question is about vitamin C.
Vitamin D, actually.
D?
D, yeah, because I read a couple of studies that it prevents, it's done for the influenza, actually, the flu. But is there any role for the vitamin D in COVID-19?
Well, we'll see. We'll do vitamin C and vitamin D.
So the BCG, there are two studies. One from, I think, New York Institute of Technology. It was early on during the pandemic. I looked at those countries where they had BCG vaccination policy compared to countries who did not have. And they found that the severity and the incidence of COVID-19 was higher in the countries where they did not have did not have BCG vaccines policy. However, it is only an observational study. It is epidemiological study. It's in the beginning of the pandemic. They did not include the countries countries were at different stages of the pandemic. So it would be very early to define that clearly. And then another study came from MD Anderson and Baylor College, which confirmed the same thing. So it looks like there is some association, and that one from MD Anderson came later in terms of the phase of the pandemic. And now MD Anderson, Baylor with MD Anderson is doing a study for healthcare workers. And they're doing BCG vaccination for those who are not vaccinated and want to see follow-up within 2 weeks after that in terms of their rate of getting the disease between the two groups. So I think we need more data before we can say that this is the case, but it looks like there is some association, but it is not at a high level in terms of the evidence.
Everyone knows about vitamin D, vitamin C, and zinc. Now we have zinc also. I'm not aware of any.
I can answer. I'm not aware of vitamin D. However, with the zinc, it is in what, and we use it actually. We approved it at our hospital where we're using hydroxychloroquine with zinc. As I said, the mechanism of action for the hydroxychloroquine is by increasing the zinc inside the cells. So we added the zinc as a supplement, but the evidence for this is very, very weak. We don't have good studies. It's just theoretical basis, scientific basis, because of the mechanism of action of hydroxychloroquine. Now, in terms of vitamin C, it's extrapolated from the data that used by, what's his name, Paul Marik. Paul Marik is the first one who described using vitamin C along with thiamine and hydrocortisone. And he was actually, I worked with him at Wayne State University during my fellowship, and then he went to other places. And it was a very small study. And with the bigger studies, there's improvement in ARDS patients with sepsis. However, there's a lot of flaws. There are a lot of flaws in the study. So we have made a decision not to use it. I think there's another recent study, but this is all before COVID-19. This is not related to COVID-19. Now they are extrapolating this data to apply it in COVID-19 because of the ARDS life picture associated with it, and hoping that anything is going to help. And I think there's 1 or 2 trials about vitamin C that we need to see the outcome of this, but those are very poorly designed trials. Vitamin D, I have no idea.
So there's a question that was asked twice. Any idea about the difference between oral swab and nasal swab?
initially when the pandemic started, we were doing both nasopharyngeal and oropharyngeal, and it's because we don't know yet which one's going to give higher sensitivity. And of course, we don't have the performance characteristics yet, but the initial data showed that nasopharyngeal swab is better in terms of sensitivity than the oropharyngeal swab. So what we do right now is only nasopharyngeal. But I think the point that either Abdulrazak or maybe Imad mentioned is very accurate, that the lower respiratory tract specimen is much more sensitive than the nasopharyngeal swab. Nasopharyngeal swab is sensitive only in 60 to 70% of the sensitivity is 60 to 70%. However, it goes up to 90% if you get lower respiratory tract specimen. So nasopharyngeal is better than oropharyngeal, and certainly lower respiratory tract is much better in terms of sensitivity.
So anyone has an idea when this will end?
This year.
You think so?
Well,
according to Trump, it's going to end by Easter, which is today.
Well, Easter is around the corner, actually. And we're far away from it. However, you know, we don't have immunity to this virus. So without immunity, we will not get
No.
I have a question, especially from infectious disease standpoint. If somebody, a healthcare worker, gets the disease, does that confer immunity, or like you can be reinfected?
Okay, so let me answer the first question. So we need to develop immunity, and there are two ways to develop this immunity. It's either by contracting the disease or by getting vaccine. Now, contracting the disease, in order to get what we call herd immunity, it requires somebody is, you know, if you can actually mute yourself would be great, if you're not talking. So in order to get herd immunity in the community, we would need 60% of people to be infected. The 60% with the non-mortality rate associated with it, like now in the States, 3 to 4% here so far, because I think we're going to have higher than this. It's going to be a lot of human lives. So the second thing is going to be by vaccine. And vaccine is going to be 12 to 18 months. I think the most promising one is the one coming from University of Pittsburgh, which is the micro needle array based on the spike proteins of the virus. It's going to start clinical trial in mid-April. I think it's very promising because they can scale it very rapidly. So I think by 2021, we will have the vaccine. Now, till we get to the point of that vaccine, we will have waves. And those waves will depend on the interventions we do in the community. When we weaken those interventions, we're going to start seeing more cases. But it's okay, because actually the problem with this, of course, people are going to die, I'm sorry, but the problem is we don't want to overwhelm the healthcare system. They die more if we get more patients in the healthcare facilities. The other thing is we give more time for medications to be developed. So we may have a cure, we may have something that may work more effectively than what we know right now, and we can probably lessen the severity of the infections for those patients. Now, in terms of the immunity after contracting the disease, in mice with that vaccine, they developed good immunity, and it's very similar to the studies. In fact, the vaccine was actually developed first for SARS-1, and then they did it for MERS, but it never completed because no funding, because the MERS was at a smaller scale, and the SARS was terminated completely. And the antibodies stayed for a long time, more than a year in the first study, actually, and they expect it's going to stay for a long time here. Now we're seeing some reports here and there that immunity is weakened after the first exposure. I haven't seen yet good studies looking at the antibodies generated after the infection, but there are reports. about good IgG and IgM levels. IgM will fade within 2 or 3 weeks, and then IgG will go and stay for longer time. We need to see long-term studies looking at the persistence of antibodies after the infection. And this is also related to whether the virus can change itself or not. So far, the virus had changed probably more than 300 times, but those are minor changes. They did not affect the major proteins responsible for the immunity and the IgG level in the body.
Okay, I think it is time. We are 3 minutes over time, so sorry about that. But it is time to close this. Maybe closing remark from Dr. Fuad.
I hope you guys can hear me. I'm sorry with the electricity and internet problem. I just using the cell. Can you hear me okay, Ryan?
We can hear you now.
Okay, so
with no electricity, what's going on?
we just had a small storm in Michigan that kind of affected our area. So thank you very much. We had good attendance, more than 100. Shadi can give us more detailed, very positive feedback, but we would like to do more. We have Ohio chapter, they running this, I think Sunday, another COVID session that we're gonna be sending by email. On Monday evening, we have a presentation and the discussion about mental health issues and coping during the COVID crisis for healthcare workers. So we'd like to attend. There will be 2 psychiatrists attending, and it will be more open discussions, will be less presentations. Sounds like there's a lot of interest in more COVID and maybe even non-COVID webinars, and that's what we're going to be trying to do in the next few weeks. So please stay tuned to more of these webinar, and we'll appreciate any feedback, positive or negative. This is the first one we're running, and that's a change from our previous CME program. So thank you very much for attending. And thanks for our speakers, amazing work, and thank you for sharing your experiences. I'm sorry for the attendees who were not able to get to all their questions and make them participate more.
Okay.
Well, thank you, everybody. Please don't forget to submit your CME to this email on the screen with the information required to claim your 2 hours CME category 1. Thank you so much.